Good morning, Borodar, and welcome, Croiser, to our webinar on shared lives and mental health crisis, which we hope will be informative, engaging and inspiring. We have lots of speakers to give you multiple perspectives on the work, and there will be a chance to ask questions at the end. So please use the chat function or the Q&A function. You'll see those buttons at the bottom of your screen to post your questions, and we'll pick those up at the end. My name is Benna Waits. I'm Joint Head of Psychology, Counselling and Arts Therapies for Aneurin Bevan University Health Board, and I'll be chairing and presenting this morning. So that brings us on to our Q&A session for our panel. And I think we'll start with a question from Kerry about whether there was any, so this is for Emma, I think, whether there was any bespoke training that you needed to offer for carers as part of this project.
So all of our carers have undergone the mandatory training as part of the Health and Social Care Induction, Kerry. But in addition to that, they also undergo mental health first aid training. And we have ongoing carer support meetings where we have guest speakers from the health board. Then we may have Benna or one of the home treatment team managers who come in and offer our carers then sort of their views and perspectives and answer any queries that our carers may have. But there's no specific bespoke training that our carers utilise, as Mags is really well trained and has a thirst for knowledge and continues her own personal development. But to enable her to support people so successfully as she has, Mags just uses her human skills and her life experience. And this is what we find with many of our carers. They've supported friends, family, work colleagues through a difficult time, have just been a ear to listen, a safe pair of ears to listen, and offered somebody time and space. And we found that that's been, to be honest, very effective.
That's great, thank you, Emma. And this question comes up quite often, actually, doesn't it? And I think what's really interesting is there's an expectation that carers would need specific training in mental health. And exactly as Emma says, that in fact, what we're relying on is the carers' compassion, humanity, and that actually is what's needed. A novel from crisis teams going in, people to respond to questions. So a couple of questions. I'm going to move on to Linda Woolley, who had lots of questions, so we'll whiz through some of those. There was a question about whether we're moving people straight from the community, which I can answer very quickly. So it was always our ambition to make this scheme available for people really quickly. So from crisis assessment to being placed in the scheme, and we're getting to the point where we've got nearly half of our arrangements that happen in that way. So you're assessed by the crisis team, and an arrangement happens very quickly immediately after that, without people needing to come to hospital. When we started, we were more cautious about doing that for lots of reasons. So we're hoping that as time goes by, that will be what more and more of our arrangements look like. There's also a couple of questions about, something about suitability and criteria, which I'm happy to pick up, although Emma, if you want to jump in, please do. So essentially, it's interesting, the host family scheme in Hertfordshire, when we visited them, had criteria, and we looked at that and we talked about it along with our service users who were helping us to plan the service, and ended up feeling slightly uncomfortable about that process. So actually what happens now is a conversation with the crisis team and the service user. The crisis teams do make clinical decisions about people that they feel will benefit from a shared lives arrangement. So it's not routinely available to everybody, but where the crisis teams think it will work, they will absolutely offer it. And that's based on their clinical risk assessment, decision making and so on. So it's very carefully thought about, but we don't choose to put it in a list of criteria because that hasn't felt like it reflects the kind of nature of the conversations that happen. Is that fair to say, Emma?
Yes, very much case by case, as Benna said, and it really is about that matching process then, and we will take the information from the crisis team nurses and present that to the carers that we feel have the right skill set to be able to work successfully with that person. And our carers then are able to make the decision. And quite often we will have a three-way conversation where the nurse who knows that person the best will speak to our carer also and share some additional information that perhaps is not in the paperwork to offer any reassurance or answer any questions or queries.
Yeah, absolutely. I've got a question. There's one from someone about the financial model and also about crisis team and whether they have additional staffing. So I might pick up both of those together, and then we'll come on to a question about when it hasn't worked, which I'll offer up to you, I think, Emma. In terms of additional staffing, yes, we have provided a small amount of additional staffing to our crisis teams to make it work. And from a financial model point of view, I'm not sure if the question was, so I haven't got the details to share with you. As I said earlier, it's funded by Health, so the scheme is commissioned by the Mental Health and Learning Disability Division within Aneurin Bevan. So at present, when we do our calculations around adding up what this service costs compared to inpatient care, it doesn't look like, when you factor in all of the additional costs, it doesn't look on the face of it, if you just take the cost per week, that it is cheaper than inpatient care. But that wasn't really the reason we were doing it. We were doing it because we thought it would be better. We thought it would be better for people and their families. We thought it would give them better experiences, and we hoped that that would lead to better outcomes. And that absolutely seems to be the case. And of course, the thing about getting better outcomes, as I said earlier, is that there is cost avoidance within that. So all sorts of things happen when people, when you support people's recovery journeys better. So they're less likely to use hospital services, they're less likely to use other services. And we're not at a point at this moment in time where we've been able to calculate those cost savings. So I hope that kind of attends to that question about the finance. Question about when it hasn't worked, and actually it's been incredibly low numbers, I think, in this group of people where it hasn't worked. The question was, how do you support people so that it's not detrimental either to the person or to the carer? I don't know if you want to pick that up in terms of how that's been addressed.
Yeah, of course. We have had a couple of instances where the arrangement has had to end earlier than planned, and I would say the majority, and there's literally less than a handful, and there have been instances whereby the crisis team have utilised shared lives instead of somebody coming onto the ward. And of course then there's close monitoring, and perhaps after a night or two, once the home treatment team are visiting and having feedback from the carer and from ourselves, and it's quite evident that perhaps the individual's mental health has declined, and then it's most appropriate then for them to actually come into the ward rather than remain in shared lives. So it's been an opportunity to try shared lives, something different, rather than the ward environment. And it could well be that the individual, in the two instances I'm thinking of, the individual has said that they would prefer to try shared lives and give that a try first, but their mental health has declined, and so they've been assessed further and needed to come then into the ward. But I wouldn't look at that as a failure, and that's the way that we feed back to both our carers and then to the individual in due course, when they're feeling more stable, is that we tried it as an opportunity, as an alternative, and it may be that it wasn't right at that time, but in the future it may be the right service for them if they are in that position of crisis again in future times or months.
That's great. Through as the chat, either of those are fine, and we're keeping an eye on both of them. Government policy and how this should, I guess, thought about. And I wonder pick this up scheme more broadly, because of course in relation to our evaluation, which is quite an intensive use of kind of staff time to support these placements, that's slightly different, I think, to the wider picture. I think Alex referenced this earlier, but do you just want to pick up that question around government policy, Catherine?
Sorry, I lost your connection then, Benna. Could you repeat that question for me?
So sorry, yeah, just about government policy. So we had a question earlier about how government policy should be impacted by shared lives and these kinds of developments. I was clarifying that the costs for our specific bit of the scheme are probably higher because it's quite intensive in terms of the staffing that we put into it. But I know there's some data around savings in the wider shared lives scheme and how that might, how that should be impacting government policy more widely.
Yes, we have done cost comparisons previously with several councils. They are consistently showing shared lives is around 30,000 lower cost per person per annum. And we're asking councils and governments to invest in shared lives for its better outcomes, as you talked about there, Benna, and on an invest to save basis. So, you know, we've heard evidence there of family homes as opposed to care homes. This can form part of the strategic analysis provided by Shared Lives Plus that I talked about earlier. We look at those cost savings and we can access the cost avoidance that you talked about earlier with regards to the additional A&E, trips to A&E, the ambulance service, GP appointments, fire service, etc. Some of those graphs explain very, very well how the reduction in all of those sort of emergency services being involved, and that has an ongoing cost effect, hasn't it? So at Shared Lives Plus, we work with government, we raise awareness. Recording this webinar, this will be shared widely to the new mental health policy minister in Welsh Government, as well as with Eluned Morgan. So we're doing our best to make sure that this fantastic service is shared far and wide and will be replicated.
Lovely, thank you, Catherine. And just for clarification, so there's a question about whether there are any costs to individuals using the service. There absolutely are not. So just to be really clear about that, so carers are paid a weekly rate, but individuals, it is essentially like receiving NHS care. So yeah. Now I think, unless I've missed any, I think the remaining questions for us are around whether we can share the presentations. I think that's come up at least once from today. So I'll need to check because we haven't discussed that in advance, but I suspect we would all be happy to share our PowerPoint presentations so we can email those out to participants. The other thing though to be aware of is that this webinar, we hope, will be available as a recording for you to refer people to. So if you've gone away and you want to think about doing more of this and you'd like people to understand it, it should be available in its entirety for you to watch on the Shared Lives Plus website. So watch this space, but we're hoping to get it up there as a resource for people. So I think there's probably, let me just check before I make some closing remarks, but is there anything from any of my fellow panelists that anyone wants to say before we finish or wants to make me aware of just before we stop? So Catherine, Emma, Nikita, Mags, anything that I need to highlight before I finish?
I don't think so. I was quickly scrolling through it to check we've answered all the questions. So hopefully we have, but if not, people can get in touch.
That's great, absolutely. You've got our contact details in the PowerPoint. So yes, it's just really a huge thank you. I want to start by thanking Nikita and Mags. I think the whole business of presenting and webinars, it's a very it's quite a challenging thing to do. I'm really sure this is a first for a number of people on this call, but I know it is for Nikita and Mag. So I want to thank them so much for talking so beautifully about their experiences of it. And it's so lovely, as Catherine said, that sense of the film has been a huge resource for us in terms of sharing the word, but actually to hear in a bit more detail from both of you about how it's been and to see where you are now is just fantastic. So thank you so much for doing that for us together. I want to thank want to thank Emma for actually just all of her amazing work with this project, Catherine and the Shared Lives Plus team for hosting this webinar and being up for doing it. We've pulled it together relatively quickly. We were really keen to do it off the back of the World Health Organization launch last week. So delighted to have been able to do that this morning. And thank you to all of you for making the time to come and join us and hear about this. We really hope it will, we hope it will spread and share, and that there will be little bubbles of Shared Lives for Mental Health crisis in other places, and hopefully it'll be easier for people to set it up because of the experiences that we've had and that we've shared. So thank you so much for being with us, and with 2 minutes I'm gonna finish off early and give you the gift of 2 minutes on this sunny day. So I hope you get to move around and stretch, because we all spend a lot of time locked on our screens, don't we? But thank you so much for being with us, and goodbye.